intervention to address these things. And I think that can be summarized very briefly in that any counseling model that empowers the patients and helps them respond in healthier ways to the stresses of life will improve the quality of their lives, will improve their health in general, will positively impact the course of their diseases, certainly including cancer, and will improve the quality of death. I'm still 9 minutes ahead of schedule, so I'm getting happier as I go. Slower? Good. Well, I'll use up a little bit more time. What I would like to do is to highlight what I consider to be the significant research in the area on the emotions in cancer. And these are 4 categories. The research that addresses the cancer-prone personality, is that slow enough? Good. I need all of the help I can get. Number 2, coping strategies associated with length of survival with cancer. Counseling used in the prevention of cancer. And finally, counseling associated with increased survival times with cancer. The first is the oldest. We looked at the research on the cancer-prone personality. LeSean is the accepted historian. He did 2 major reviews of the world's literature in 1956 in the British Medical Journal and in 1959 in the Journal of the National Cancer Institute. Art Schmally did the first prospective study looking at personality factors as predictors in the development of cancer of the cervix, and this was reported in Journal of Psychosomatic Medicine, 1966. Again, this is not new stuff. C.B. Thomas from Johns Hopkins did the first major prospective studies looking at senior medical students at Hopkins and reported her findings in 1974 with the wonderful conclusion that she had shown prospectively what LeSean and Bonson had shown retrospectively, and that was indeed that there was a cancer-prone personality. And finally, the largest volume of work and the most recent comes out of Heidelberg, West Germany, that was started in Yugoslavia by Ronald Grossart-Maticek, and he has reported multiple studies with large populations in excess of 1,000 people followed for long periods of time, all of which exceeding 10 years, some up to 20 years in length, showing the existence of cancer-prone personality. And the essence of the cancer-prone personality is a tendency to respond to stressful situations with a sense of hopelessness. That hopelessness was very adequately described, that depression, by Dr. Evans in the chronic pain patient with depression with repression. It's a repressed depression, so it's not an obvious depression, and this has led to some of the confusion in the field. The bottling up of emotions is the other very major factor. The cancer-prone person is described as too good to be true. They tend to be overly compliant in general. They're the nice people. And in medicine, that's what's always been said. The nice people die young, the mean ones, you can't kill them with a stick. Okay, and looking at coping strategies associated with length of survival, there are 2 authors that I think are very important to note. One is Derogatis, also out of Johns Hopkins, who reported his findings and coping strategies as associated with increased survival in breast cancer, and that was reported in Journal of the American Medical Association, 1979. The huge body of work that was stimulated because of Derogatis' work is Greer's work, also looking at coping strategies as associated with survival time in advanced breast cancer, and that's reported his 10-year study was reported in Lancet October '85, and his 15-year follow-up was recently reported also in Lancet this year, January '90. In the area of prevention of cancer with counseling, the work there is a single author, Isink and Matichek's work, and they've published theirs a number of times, but once was in the spring of '89, using minimal counseling, again taking cancer-prone personalities, randomly dividing them and counseling one group, and dramatically impacting the incidence of cancer. I think some of the most exciting work that's come out of medicine and is being routinely ignored. Huge volume of work that Matichek has done. I had a chance to visit him in Heidelberg last summer, and he's been involved in this work since 1966. I don't think anyone will ever equal the volume of work that he has generated and continues to generate in the field of psychosocial oncology. And number 4, looking at increased survival as associated with counseling. I reported on this in the Journal of the Australian Medical Association in 1981. B.W. Fig Newton, who many of you know, who also was a student of mine in this area, reported his results in 1982 in the American Journal of Clinical Hypnosis, and found actually better survival times than I did in his patients. Ainsley Mears from Melbourne, Australia, also reported the impact of counseling and increasing survival times with people with advanced cancer. No one comes close to the volume of work again of Ronald Matichek in this area, and he and Isink have reported this in a number of places. The largest review article being in Psychology Today, December of 1989. And finally, the crowning study, which was a study that was undertaken in an attempt to disprove my study in 1981 by Stanford, found almost exactly the same results that I did in counseling breast cancer patients, using a different model of counseling, but still counseling people with breast cancer, when they found a doubling of survival times compared to a matched control population. This was a 10-year study and reported in Lancet, December of 1989. So looking at the literature, if we have any interest in this field, to me, we cannot help but appreciate that this is a fertile field. And so what do we do with this information? Well, number one, we don't say, well, let's not get patients' hopes up that counseling might impact survival, or that this might be helping, but trying to do it in a balanced way, presenting people balanced information. That's what I think we owe to the people that we work with as responsible physicians. That to be overly conservative is as unhealthy for our patients as it is to be overly optimistic. And attempting to be honest and balanced and to admit that we don't know and to be willing to walk that road with our patients is the essence of what this work is about. I'd like to spend a few minutes looking at basically what has been agreed upon as far as counseling models and dealing with persons with malignancy. And I had the opportunity of sitting in a closed session in Tutzing 2 months ago over south of Munich. And for the first 3 days, the basic scientists argued back and forth about the role of the immune system in cancer and research design and psychoneuroimmunology, and many of us sat there using every hypnotic technique we knew to keep ourselves from needing to leave or develop illness in the room. And finally, the last 2 days, we found basically that there was consensus, and that's very exciting, that there was consensus on what do you do with the person. which was very exciting because no consensus could be gained about what was being observed from a basic science standpoint, and absolute consensus about what was the most effective therapeutic approaches. And I'd like to summarize what we agreed upon at that meeting. Now, the important aspects of psychological intervention in cancer therapy have been elaborated by a number of authors. LaShawn is by far the most published in the field. Bonson has written extensively. Matichek has written a number of good articles. I've written on this, and many other people. In general, the therapy needs to be relatively gentle, and that's important. It needs to be gentle, acknowledging the vulnerability of the person with cancer. And LaShawn pointed out very accurately that it's important that the focus of therapy be with what's right with the cancer patient rather than what's wrong with them. I think this is a very important point, to appreciate the importance of focusing on what's right with a person and helping them build upon their strengths, and then out of a place of strength begin to look at the pathology that has gotten them into the unhealthy place that they're in. It is so much the traditional model because of the nature of counseling. You see, people come to counseling because they're unhappy in general. They're displeased with the way that they're feeling. So it's appropriate to begin to address those problems that are causing them to feel bad. Cancer patients don't come into the arena because they feel bad emotionally. So to begin to look at what's wrong with them mentally, emotionally, is absolutely contraindicated, because now they perceive themselves not only as having cancer, but as being inadequate people from a personality psychological standpoint. This is very important to appreciate. So much of the basic training in psychotherapy is counterproductive to dealing with the person with cancer. And that's because the person in psychotherapy comes for a very different reason than the person with cancer arrives. So you begin to help the person with cancer work on what they want to work on, and then when their pathology begins to get in the way of them going where they want to go, then you address those issues. And it's a very productive way of working. The other merely tends to take a person with cancer and help them become all the more depressed, and that depression becomes much more conscious then. And it is a grave disservice. And we owe LaShawn a debt of gratitude for his astuteness in picking this up and showing that, contrary to the way he was trained and the way that people are trained in general in psychotherapy, that the approach to the cancer patient, and probably in psychosomatic medicine in general, needs to be the opposite direction. Oh, thank you. I need to speak more slowly. You see, I am in this dilemma. I want to get this all said. What is that, a double bind? I guess just long pauses don't make up for going too fast, though, do they? Okay. Based on the work of Greer, it's important that we support patients' existing coping strategies. This is very important. Traditionally, in psychotherapy, we tend to confront and attack denial. Denial is one of the most effective coping strategies for people with cancer. It's important that we support denial and help the patient develop healthier coping strategies and allow denial to be replaced as they develop a healthier coping strategy. If we confront the denial, the person tends to move into hopelessness. Hopelessness has less than half the survival characteristics as denial. So again, if we confront denial, whether overtly or covertly, then to me, we have the responsibility of staying with the patient until they develop a healthier coping strategy, which is a very, very difficult task. I did this out of ignorance for a number of years, I didn't know what I was doing. I knew that it was not good for the patients, and now it's very clear that confrontation and denial is an unhealthy thing to do with cancer patients. It needs to be done only when the therapist has an understanding of what they're doing and what's going to be involved in helping the patient build a stronger coping strategy. It's important that the therapeutic process empowers the patient. This is work that was elaborated by Matichek. If the therapy interprets reality for the patient tends to do worse than if they received no counseling. That to me is very important, because we as physicians, we as clinicians, tend to want to interpret things for patients. I notice this, and patients want us to interpret their reality for them. And I, as a patient, want a therapist to interpret my reality, because I don't want to do the work. I want the right answer. I don't want to have to stumble around for my own. But we best learn what we discover for ourselves, and that's true for all of us when we're healthy and when we're sick, when we're in the role of the physician and when we're in the role of the patient. And that's another important thing that we forget, is that we are all people. And it comes very home to us very strongly when we're diagnosed with diseases ourselves and find ourselves in the role of the patient. And we find that the healthcare providers tend to be the poorest of patients, and that is a lesson that we need to sit with and understand why that is. Any effective intervention is going to be educational in nature. It's important that people are taught the basics about relationships between beliefs, attitudes, and emotions. I believe the most effective way of teaching this, having tried a number of ways over the years, I personally believe the most effective way of teaching this is through some of the existing cognitive behavioral therapies. I've been very excited to see the emphasis on behavioral therapy at this Congress. I believe this is a major breakthrough in counseling, and I think it is, as far as I'm concerned, the most effective way of helping people understand the interrelatedness between beliefs, attitudes, and emotions. There also needs to be a clear method of determining the relative health value of beliefs. The best model I've found for this is one developed by Maxie Maltzby, and his book is Rational Behavior Therapy. Using this approach, it has greatly simplified my work in helping patients understand the relative health value of their beliefs. Once a person has a clear method of determining the relative health value of their beliefs, then they're in a position to develop greater emotional mastery of their emotional lives. And as in learning anything, the use of the imagination is central. So the systematic use of imagery is important, whether we're teaching someone golf or teaching them how to get well from cancer. Among the mandatory topics in a counseling program is systematically addressing the concepts of failure, guilt, and blame. Time's catching up with me, but I think I'm still going to win the race. Speaking slowly is not something that I practice a whole lot. The biggest single criticism that's been leveled at psychosocial oncology is that it engenders guilt, blame, and failure in patients. I believe that it's important in implementing any form of psychosocial intervention to address issues of failure, guilt, and blame initially, because those are dealt with in the same way any other unhealthy emotion is dealt with. One central concept in helping to deal with failure, guilt, and blame is that we always do the best we can with the information that we have at the time. I don't have a problem in my patients with failure, guilt, and blame. It's one of the least of the problems. When it comes up, it tends to be very intense. But problems of anger in general and hopelessness are much, much greater. Where the problem occurs primarily are from people reading bits of information, piecing it together, and then in very unhealthy ways using that information to help themselves move into a very unhealthy place of feeling increased failure, guilt, and blame. But therapeutically, it's relatively easy to deal with. Simple relaxation is one of the most important processes in psychosocial intervention. Many people, especially at the time of diagnosis, are in no place to do counseling, and what has been found to be most effective is to teach them simple relaxation. This helps people move into the space of neutral emotions, peace, tranquility. These are very healing emotional states. So I would say, as Herbert Benson of Harvard has found, and many others, one of the most healthy things that all of us can learn to do is to learn to relax and teach our patients to relax. Very, very important single part of psychosocial intervention. The roles of support and bonding are of obvious value. That's been dramatically pointed out by Spiegel's study from Stanford. Helping people find meaning in the experience of having cancer is also very important and has been known for many, many years. And finally, in any intervention process, it's important to address spiritual as well as psychological issues. I was greatly pleased to find unanimous agreement in our working group in Tutzing that spiritual issues were critical to address, and that excites me very much, because we've been very physically oriented in medicine since the time of Descartes. Only in the last 30 years have we really begun to look at psychological issues, and we haven't begun to address spiritual issues. But in addressing spiritual issues, we need to find acceptable definitions of spiritual. Where I initially went was to Webster. And Webster defines spirit as the life force, especially in man, and as the feeling and motivating part of man. The area in my own work where we most directly address spiritual issues is when we begin to work on the concepts of death and the very important concept of inner wisdom or inner being. This to me very much directly relates to many physicians' observations, including Albert Schweitzer, who one of his most famous sayings is that within each person exists a wise physician. And from my standpoint, he wasn't talking about well-educated WASPs in the United States. He was talking about the uneducated blacks of Africa. And he said within each person exists a wise physician. And respecting this wisdom that resides within each of us and within each of our patients, to me this is part of the process that supports life and is the essence of spirituality as far as I'm concerned. To gain greater awareness of those things that go by the names of intuition and gut feelings have great value in living life and in regaining health. And finding ways of standardizing spiritual concepts and developing acceptable nomenclature are essential in order to research this area. A few weeks ago, I had a chance to be in another closed group where we were looking